just quickly before we get there, there are some other things that we need to cover a little bit about gastroscopic practice. Report writing, Tamaz will come on to. Decision-making and signposting we talked about yesterday, and I think that this is something that we've pushed throughout the 2 days. But I do think that discussion with the patient after the procedure is something we haven't talked about really, and it's something critical. So if, for example, you don't go and talk to the patient after you've done the procedure, and of course, if they're awake, it's easy, you talk to them immediately, but this is predominantly directed at either a therapeutic situation or whether the person has had sedation, et cetera, then it's very, very important that you talk to the patient. And what do you have to say to them? Well, you have to talk to them about follow-up. And this is so critical because, of course, a lot of the times when patients get problems and they get missed cancer and stuff, that's because they just didn't come to surveillance. And maybe they didn't come to surveillance because someone didn't explain to them why they needed to. So that's very important. You should be effective at communicating. I think another very key feature about this is alarm features. So as a patient, what should I look out for after the procedure if I have a problem? Of course, you need to evaluate what's going on with them. You need to understand a lot of the things about it, but really also you need to think about, well, yeah, maybe what did I do to the patient and what can that bring later on in terms of intervention and potential risk of hospitalization. And you need to think about, well, what did in the procedure? And you need to tell the patient, for example, say that you did a cold snap polypectomy in the stomach, for example. What is the chance that that's going to be a problem? And then talk to the patient afterwards and say, okay, I did XYZ thing. We found this, but we did this procedure. You know, is the patient planning to travel the next day and get on a flight or something, for example? Not so relevant if you did cold snap polypectomy, but maybe did a dilatation. Maybe they need to resume their anticoagulation. You know, we have many, because I'm doing a lot of therapeutics, you see the sharp end of the adverse event spectrum. And of course, yeah, if you don't inform the patient, then maybe they start taking their anticoagulation the next day. Maybe they already planned in advance to go flying the next day. And then on the airplane, they have significant rectal bleeding or something if you did, or melena if you did an upper GI procedure. So these things you have to think about. And in the curriculum for EMR, we, I think, quite categorically set out the things that you should talk to patients about. And the other thing is this, which is, okay, you have a well patient, you fit patient, you do your procedure, they go out of the room, you talk to them, but you say, here are the risks, but they go home. But when should you think, actually, I should admit that patient? So for example, say that you have a patient on anticoagulation, you do a dilatation after the procedure, it's bleeding. Are you going to let that patient go home? Maybe you did a dilatation, and you see that it's maybe a little bit of a muscle tear, you're not sure. Maybe you should admit that patient. I think if you're ever thinking, I'm not sure, what would happen if this patient went home tonight? I'm not sure that they would be fine. You should be considering whether or not you should admit them. And of course, this will be very much dependent upon your healthcare environment. You also have the patients who, you find something. This is the first diet. So maybe the patient has been struggling for a while in the community, can't eat, decreasing oral intake. You find a stenosis which is either malignant or you think is not going to be easily managed that day. Their calorie requirement is poor. They're losing weight. Maybe you need to think about admitting them at the time. A very important one is there someone at home with the patient? So that's relevant to sedation, but that's also relevant to therapy. So we had a patient who came to serious harm because we sent them home after a therapeutic procedure, and we knew that they were in sheltered accommodation, but we didn't check what that meant. And actually that meant they lived in a house on their own with no one in the same building, but that they could press a button to get help. But they were so unwell that they couldn't press the button. And so they were, it was a near miss, I think that. So supervision at home probably means someone in the same building if you've done a therapeutic procedure, or someone that will wake up if there's an issue. Do they have some special knowledge they need to follow? Do they need to take a certain amount of medication for a certain amount of time for something that you've done? What is the follow-up for the Helicobacter that you've just tested? What do they need to think about? Maybe put a safety net in so that they end up, if they don't get the report because the administration system breaks down, then they know they can call or they will chase it up for you. And I think it's very important to tell them what they should look for. So, for example, if we're doing any Barrett's resection, we say to the patient, if you start vomiting blood, but also if your stool turns black or you get severe pain, you should present to a hospital. And you probably shouldn't travel for a week after such a procedure to a place of isolation or on an airplane.